And I think last but not least, just kind of thinking about looking for dementia in the primary care setting is that only about 50% of older adults who have Alzheimer's disease in the community currently are diagnosed. So it is a very underdiagnosed disease, and we can think of a lot of reasons why that may be. But as you all know, and I know in a busy primary care practice, it takes a lot of time to evaluate for dementia, and it can be masked by good sort of family or social support. So we'll think a little bit more about that.
Anything else on the list that you think might be an issue?
Simvastatin.
Simvastatin. He has this vague coronary artery disease history. We don't know if he had a recent stent. Maybe. What's that?
He's more than 80 years old. It's going to take 10 years for benefit.
Exactly. What is the likelihood that he's really going to get benefit from that simvastatin? I agree with you.
So she follows with a rheumatologist, a cardiologist, a GI specialist. She makes comments of a pulmonologist who's told her she should not exercise and is looking to change all of her specialists. She just got discharged from the hospital after being evaluated for the shortness of breath earlier this week. So she came with a list of over 25 medications that she's on. And the list that I provided is actually, she got hospitalized a week after I saw her. So this is the list that came back to me after her second hospitalization. She has both ulcerative colitis and rheumatoid arthritis. So we talked a little bit about who was prescribing that, whether that was coming from her rheumatologist or whether that was coming from her GI specialist, so that whoever she establishes care with, we can have that conversation about whether she still needs to be on Humira and could that possibly be causing her shortness of breath.
Mm-hmm. Yeah, I totally agree with you. I think with this patient, it'll be important, a lot of her drugs, we do need the input of specialists, especially her RA and ulcerative colitis drug, to figure out. I mean, she has several different immunosuppressives that could be used for either of those illnesses. And I agree with you. I think they're high risk, and we need to figure out with the help of her specialists, her soon-to-be specialists, what to do with them.
I just wanted to mention that this patient actually came to you for a second opinion, or a third opinion maybe. And she has not been compliant with instructions in the past from the other practitioners or from the other doctors. So I think your role, like you asked, what is your role? I don't know if your role is to start doing all those things, because I believe either they have been done in the past correctly and completely and on time, or she has refused them because she did not understand what their use and implication. So your role will be more of educating her on the importance of these things and the timing and the wastage and the risks actually of having more than one or twice.
Yeah, I think that's a very, very important point. Yeah. The reassurance and knowing that there's a limit, we can limit patients in sort of these repetitive screenings with just developing a relationship with the patient, reassuring her that she is okay, and you have reviewed her prior mammograms, and you are getting her back to the vascular surgeon, and that you acknowledge that she's concerned, but that you feel that this is probably unlikely to be a breast cancer. Mm-hmm. Very good.
Yeah, I think that's a great point. That really points out the value of primary care too, is that you're going to be the one that she looks to as kind of her doctor, and the central nidus when there's all these specialists going on everywhere. And you can really, like you said, the doctor at St. Bernard said, you can minimize sort of waste to the system, but also risk to the patient by having that relationship and sort of coordinating care. So I think you made really good first steps, and I think your goal of going over all the medications from all the specialists at the next visit is awesome.